the default way people really talk about payer-provider negotiations is usually adversarial. Payers want to minimize cost, providers want to maximize revenue, and obviously there's certainly a truth in that, but it actually misses the root cause of most of the friction. What we've observed, having worked on contract analytics with dozens of different provider organizations, is that the bigger problem is structural. Providers and payers aren't just negotiating from different positions, they're negotiating from different information sets, different time horizons, and fundamentally different definitions of what a fair market rate even is. The transparency and coverage mandate created a public record for the first time of what payers are actually paying code by code, provider by provider. That didn't exist 3 years ago. But access to that data is deeply uneven. The files are massive and they're technically complex by design, so the information gap hasn't closed, it's just shifted. So starting at the top left, when you analyze transparency and coverage data within a single metropolitan market, same payer, the same CPT code, the same city, the rate variation between providers is routinely 30 to 60%. I want to reiterate that. The same payer, the same CPT code, and the same city, the rate variation can be between 30 to 60%. It's a pretty staggering difference.
First is, what is the sustainability of care delivery? We have the overheads, clinician compensation, and all that's tied to CPI index, basically consumer inflation over time. And then the second is effectively provider access and network alignment for the patients. We're telling the insurance companies, ultimately, if they're not generous enough to the providers, they'll defect from the pool. And then the third really is making sure that the rates that are provided and the codes that are reimbursed are predictable and consistent.
I would say for us, some of the top priorities that really guide our strategies is really twofold. One, do we have all the information that is necessary to make this discussion or renegotiation or expansion? And two, how armed are we to make that decision? How informational are we in terms of our decision-making process? We understand that payer-provider negotiations are never an easy process in any way, shape, or form. They are difficult, they are laborious, they are stressful, and we want to maximize what we're doing simply for the fact that when we're providing services, we want to be paid as much as we can for that services, as the services are not easy to administer or take care of. But we also understand that there's a limitation. And so knowing that we have all the information armed with that and going into a discussion point, we're not going to ask for something that is the sun, the moon, and the stars. We're going to ask for something that's realistic.
That is public. Why aren't providers systematically using it? I think it's a new data set for them that they haven't known about. It just launched in 2022. It's very easy to focus on care for several years and then realize, okay, time for renegotiation, and then learn about this new tool. But it's not the kind of data that you need every day or every hour, because it's a once a year or once every 3 years for some insurers type of process. Preparing, at a minimum 3 to 6 months in advance, just getting the presentations ready, materials ready, what's the rate request that we're going to have, and it really helps the provider groups negotiate apples to apples with the same knowledge that the insurers have.
Most practices have never looked at whether their payer contracts even cover the full scope of services they deliver, not just the rates, just the code coverage. How common is that gap, and who's responsible for closing?
Yeah, there was a situation even recently where, we signed the contract, went through the whole credentialing process. I was the one who literally signed the contract, so I know it was active. And, we were billing standard CPT codes, right? Standard behavioral health CPT codes. And it kept coming back as provider not enrolled, provider not credentialed, prior authorization not received. None of that was ever in the contract. And it took about 4.5, 5 months to really escalate it. And they came back and they said, oh, at the end of it, you were right. We reviewed your contract, we reviewed your codes, you've been billing the right codes. We're going to reimburse you for all of those visits that we denied you. And it was hundreds of claims. And she said very simply, I don't want to say this out loud. And this was her words, not mine. She said, I don't want to say this out loud. And we were just on a call, she and I. But she said, we made the mistake. She's like, you caught us, we fixed it, but we made the mistake. She's like, I'm not supposed to tell you that, but I am.
So looking ahead to 2026 and beyond, what changes do you expect in how payer-provider contracts are structured or negotiated?
So I think that's one. I think so data-driven focus is one key factor. And then two, I think more proactive contract management. I think there'll be a push to get away from the 3-year terms, perhaps more transparency, more benchmarking, more frameworks, and more push to the insurance companies on what are ways we can show better outcomes, better metrics, and have that link to better reimbursements.
There are going to be direct providers who aren't going to contract as much with select payers, regardless of how large they are or how situational they are. If they've had a bad experience and something, just doesn't go their way, they're going to look elsewhere. They're going to limit, the contracts that they take, the agreements that they make because of past issues. So the more information you can provide that make your practice seem strong and dedicated and loyal to providing the services, the better it could be for everyone.